Today, I discuss on the topic, the muscle tone and its regulation. Here in this picture, that gives the brief outline of the basis for the muscle tone that I am going to describe during my discussion. What is muscle tone? Muscle tone is defined as the tension in the relaxed muscle. So look at that. There is a tension and there is a relaxation. How can it be possible? Tension in the relaxed muscle. No, definition may not be fitting to the or describing the importance or the significance of muscle tone. Then comes the resistance felt by the examiner during passive stretching of a joint when the muscles are at rest. Or else it's the partial state of contraction which exists in the muscle at rest. Or it can be the tonic reflex activity of the myotatic stretch reflex at rest to maintain the length and the tension in the muscle at rest. This is more physiological. It's a tonic reflex activity of myotatic stretch reflex at rest to maintain the length and the tension in muscle at rest. Okay, so the last definition appears to be a more meaningful, more physiological. Now coming back, I would like to just pose a question. Suppose the muscles are attached to our bones. Usually they are attached to the tendon, some bony prominences. They start from the bony prominence and they end on the that means end on the bony prominence. Maybe between these bony prominences, some joints come in between, so that to produce the bending or a flexion extension of that joint. Suppose if you cut the tendon of the muscle, what happens? It shortens. What does it mean to you? That is the basis of muscle tone. So that means when at rest, the muscles are stretched. When the muscles are stretched, there will be activation of certain reflex activity, which is operated at the segmental level. And this reflex activity represents the muscle tone. I said, when you have cut the muscle in one end, so the muscle shortens. The muscle will not remain same, it will shorten. And this shortening of the muscle indicates that the muscle is being stretched. The stretch of the muscle, that itself initiates certain important neural signaling that in turn activate the spinal reflex activity, what we call it as a myotatic stretch reflex. And then that would try to make the muscle remain in a partial state of contraction. That's what the muscle tone is. Now you got it. Why I chose the third one is more appropriate. It is a tonic reflex activity of the myotatic stretch reflex at rest to maintain the length, because they have been placed at a higher length than before, than exactly are. Length and the tension both are complementary here. The tension is a different, that is a force, and the length is a dimension. So now at rest, both are to be, they are kept at particular length and tension, and the muscle will interact with the myotatic stretch reflex and produce the tone. Okay, having considered this, we move on. The clinical definition defined as the constant muscular activity. Now you can understand that it is an activity, constant muscular activity that is necessary as a background to actual movement in order to maintain basic attitude of the body, particularly against force of gravity. That means this particular tone is important as a background activity for the postural maintenance or postural balance, especially the maintain as a anti-gravity activity. Okay, that resembles the previous definition. It is a tonic reflex activity or a partial state of contraction due to the myotatic stretch reflex at rest to maintain the length and the tension of the muscle at rest. Now, the second part, thus the tone can be a construct that is required for the motor control, such as it has both static and dynamic tasks. One at resting part, and when the muscle is contracting, that is a dynamic state. And in both the states, it should have some amount of a basic requirement base, and that can, and over which the muscle can contract and perform the action most efficiently, and especially most efficiently in the thermodynamic aspect. That is the definition of the muscle tone. I still restrict myself. It's a partial state of contraction or a tonic reflex activity of myotatic stretch reflex at rest to maintain the length and the tension of the muscle at rest. Or if you are asked in the clinical lab, it is a resistance felt by the examiner during passive stretching of a joint when the muscles are at rest. Okay, so now having been said that, what are the components of the muscle tone? So now, basic component of the muscle tone is primarily the components that govern the myotatic stretch reflex activity. And they are: one, active component; number two, passive viscoelastic components. The active components depends on the neural activity and the contractile activity of muscle by the stretch reflex and its variables. I will detail these things in the discussion to come. Now, the passive components, the passive or the viscoelastic components, these are independent of the neural activity. These are nothing to do with the neural activity. They are part and a property of the physical property of the muscle and the proteins present in the muscle. So thus, they will depend upon the sarcomeric, the contractile protein, that is the actin and myosin cross bridges, the viscosity of the muscle tissue as such, that will offer the resistance, because even it offers the resistance passively. And the elasticity of the muscle itself, because the muscle is having both elastic and the plastic components. Elasticity, that means elasticity, if you are true to physics, when you take the force, it will regain back its original position or original base. And elasticity and extensibility of the contractile filaments, that is also viscoelastic component. This is independent of the muscle nerve activity. The filamentous connections of the sarcomeric and non-contractile proteins, because we have a Z-line protein or M-line protein, and so many non-contractile proteins which are surrounding which are constituting the series elastic elements and the parallel elastic elements, such as desmin, titin, and so on. Okay, so these and the osmotic pressure of the cells, this sarcomere or the sarcoplasm, it has its own osmotic pressure, and also the surrounding connective tissue. These are all the viscoelastic components of the muscle. They will also offer the resistance, and this is a passive resistance. The active resistance is one when the muscle offers because of the neural activity. If you cut a nerve supply or the alpha motor neuron supplying the muscle becomes flaccid. The neural activity that governs the contractile activity of the muscle and the various variables that regulate this stretch reflex are the active components. Now, the classification of the muscle tone. The muscle tone is classified into two components, the postural tone and the phasic tone. The postural tone is seen in axial group of muscles. They maintain the posture and they maintain the gravity of our anti-gravity muscles, where gravity is the most important factor. It results from a steady stretch on the muscles and tendons of these muscles and manifests as a prolonged muscle contraction. Suppose you think you are sitting tight in a classroom for a long, or you are sitting a very long flight or a train journey or a bus journey. You are always under stretch, where your axial muscles are under tension, and when you reach home, you will feel that you need to unwind. Everything is very tight, so that is the postural tone. The phasic tone. This is with the distal muscles. This is commonly assessed. What we do in the laboratory, it is commonly assessed by the clinician as a rapid and a short duration response. That means you try to passively flex the elbow and feel for the resistance offered by the biceps and triceps muscles, or any other muscle in question. It results from a rapid stretching of the tendon and attached muscle, more precisely the muscle spindle. These types, either postural tone and the phasic tone, in case of active components, can either be active or passive. Passive is already I mentioned. It is the physicochemical components or physicochemical elastic components of the muscle, and the active components are the neural components. Since the main component of the muscle tone is mainly the myotatic stretch reflex, thus regulated by the spinal and supraspinal mechanisms. The spinal and supraspinal mechanisms. The spinal mechanisms include muscle spindle and spinal cord, the interneurons in the spinal cord, and the motor neuron in the spinal cord. The supraspinal or the descending facilitatory inputs, descending inhibitory inputs, and the cerebellar modulation of these two inputs in the reticular system and in the as a vestibular system. These are the supraspinal controls. Now, this is the first one. I'm looking at the spinal level. In the spinal level, it is the muscle spindle. This is the muscle spindle here. When you stretch this muscle, because I said that this muscle is always under stretch. It is stretched. When this is stretched, there are activities or impulses going from these muscle spindle. This is a muscle spindle, and they reach to the spinal cord. This is the spinal cord here. They make a monosynaptic contact with alpha motor neuron of the same muscle, and that would produce the contraction. And this forms the basis for the partial state of contraction. Right? So now, what is the stimulus for this? Here, so here in this case, knee hammer. No, it's not knee hammer. I am sitting here. My muscles are stretched to some extent. I am even stretching my legs. Even then, they are stretched. So that means it is the stretch or the attachment between the two bony ends and the stretch associated with the muscle length. Usually, muscle length is the beauty or the nature has provided the attachment of the muscle is in such a way that the sarcomere length is around 2.2 microns. Now, in this 2.2 microns, the actin-myosin interactions are optimal. There will be a maximal interaction of the actin and myosin filaments, what are called cross bridges. These are called resting length in situ. This is the in situ length, and this in situ length will have already stretched, and these stretched elements, the muscle spindles are there in the muscle, they are stretched, they increase the activity, they in turn excite this. This is about the stretch reflex. Now, what happens when this thing is happening? They will also send the impulses also reach to the interneuron, the another inhibitory interneuron here, which would inhibit the opposite group of muscle. This is a flexor muscle. This is a extensor muscle. The opposite group of muscles, the agonist and antagonist muscle, and now the antagonist muscle is relaxed. Say, for example, bending of the knee here, the hamstring muscle are to be relaxed, quadriceps is partially contracted. So that is what the stretch reflex is. This is the basis for, this is the primary reflex arc for the muscle tone. I mentioned about a muscle spindle. I will just revise what is this muscle spindle. The muscle spindle is composed of a bundle of intrafusal muscle fibers, because within this muscle, this is the muscle, within these muscles, there are parallelly arranged a bundle of intrafusal fibers, what we call as a muscle spindle. And these muscle spindle consists of a bundle of fibers, Of course, these fibers are specialized fibers. They are acting as both sensory and motor components. Their contractions are feeble because they do not have a striescence as much as that of the extrafusal fibers, and there are two set of elements here. One is a element which responds to the velocity dependent component. This is a dynamic component, and this is called a dynamic nuclear bag fibers. That means we have a nuclear bag fiber and a nuclear chain fibers. Here the nuclei are arranged in series like chains. Here they are arranged in bulbs. These are nuclear bag fibers. And in these nuclear bag fibers, one of the nuclear bag fiber is a dynamic one, and the remaining, these nuclear chain fibers and the nuclear other nuclear bag fibers are static. These are static. To understand, so these dynamic and static, if you are looking at that, when you extend or stretch the muscle, the dynamic fibers discharge, they will increase their activity. And these dynamic fibers in the bulb region and in all areas, they are supplied by the afferent nerve, that is a fast conducting group 1A afferent. This is the group 1A afferent. These static fibers at the polar area, they have a spray nerve endings. That means they are distributed all along the axis of the polar area, and they are carried by the slow conducting fibers, group 2 fibers. These are static fibers. Look here, this is the stretch. The stretch is this period. This is the wherein this stretch is increased here and then sustained. Now, when the stretch, this is the resting state. This is the resting state. The impulses, these are number of impulses. The impulses, there are very few impulses that are not recorded here. So even in the resting state also, if you go back, there are some impulses coming up. That is what is responsible for the tone. Now, so as this is stretched, as it is being stretched, it increases the activity. And when it reaches to the peak, here it reaches the peak, it drops down. And then as the stretch is continuing, it is a sustained activity. So now this difference, the peaking and the steady state response, this is a dynamic response. This is a dynamic response. The remaining part is the static response. Now, when the static gamma fiber is stimulated, because they are supplied by the gamma motor neurons. There are two types of gamma motor neurons here, the static gamma motor neuron and a dynamic gamma motor neuron. When the static gamma motor neuron is stimulated, and during the stimulation, this is the stimulation period. So now what happens? There is an increased activity. There is an increased activity in the sudden activity in the impulses, and these will reach. So when there is a stretcher, they will reach, but not as much. See, look here, this is this much, and it will reach to an extent, and then they sustain. They remain at a higher new level. That is the static activity. Now, when the dynamic gamma fiber is activated, you see that the first part is not much increase, but in the second part, this dynamic is stimulated. There is a sudden increase and then drop down, and this is the static component. Okay, so there is what is called a static and a dynamic interference between the muscle activity. Now, coming back here, now I want to mention sustained stretch of the muscle, as happens in case in our body in situ. There is a stretch on the intrafusal fiber, and that will activate these nuclear chain fibers. These are nuclear chain fibers, especially the nuclear chain fibers here in the group 2 afferents. The efferent signal, that means they reach to the spinal cord by type 2 afferents. These are the type 2 afferents. They reach to the spinal cord. So that means efferent signals reach to the alpha motor neuron and to the muscle extrafusal fibers. Already the alpha motor neurons are activated by group 1A afferents, because group 1A afferents have a lower threshold. They can be easily stimulated. So group 1A supply the entire range of these static fiber and the dynamic fiber. Already some part of the muscle is contracted. There is what is called the asynchronous activation of the alpha motor neurons, because the alpha motor neurons is already activated. This is the first one to appear, this appears second. So there will be asynchrony in the activation of the alpha motor neuron, because already something has come before, and this is coming a little later. This results in a mild sustained contraction, because this is the first one to arrive. The alpha 1A afferent is the first one to arrive, and over that the second, the group 2 afferents are coming up. So that means that results in a mild sustained state of activity, and that produces the contraction of these extrafusal fibers. As long as they are stretched in the body, they are continuously stretched. That is what the muscle tone. This static stretch reflex response is the physiological basis of maintaining a muscle tone. The static stretch reflex response generated by the nuclear chain fibers is responsible for the physiological basis, or is the basis for the muscle tone. Okay, we go it further here. If you just look at that, so we have the muscle spindle here. It is at rest. When it is at rest, there is some amount of a stretch, some amount of, and you see that the activity is there in the sensory fiber, in group 1A fiber. This activity is there. Now, when this muscle is stretched, what happens? This activity increases. You just see that increased activity. Now, here, when the muscle contracts, when the muscle fully contracts, what happens? This is not stretched. This muscle spindle is not stretched. It will be silent. There is no discharge. So now, in conditions where there is a increased gamma efferent activity, gamma motor neuron activity, what happens? Even at rest, the resting discharge is increased. Here, if you just see 3 and here it is 5. Resting discharge is increased. What does it mean? Partially the muscle is contracted, what we call as a hypertonic. This is a hypertonic situation. So this is a partial state of contraction, increased muscle activity. This is when gamma efferent activity increases. Now, during this time, when the gamma efferent activity is increased, if you stretch, what happens? The discharge is increased. This is what happens in case of a upper motor neuron lesion. In the upper motor neuron lesion, you already have the increased gamma efferent activity like this. Now, over and above, what you are doing, you are adding the tendon tap, the patellar tendon is tapped. So then there will be a burst of activity, and that produces this contraction. What we call as a knee jerk is exaggerated. The deep tendon reflex is exaggerated. This is the basis for exaggerated tendon reflex in increased gamma efferent discharge. Regulation of muscle tone is done at 3 levels: the spinal level, supraspinal level, and the muscular level. The muscular level, 3 main components, that is the neuromuscular junction, excitation, contraction, coupling, the muscle proteins. So all those units which have the muscle dystrophies or the muscle problems, that means if you are using the neuromuscular blocking agent, or as it happens in case of a myasthenia gravis, so there is a weakness and decreased muscle tone. So that is what the muscular level I was talking. Suppose if the excitation, contraction, coupling is not happening, so that again, that is another situation where the muscle contraction does not happen, the tone may be decreased. What happens in case of the familial periodic paralysis because of the increased potassium levels? Or in case of the muscle proteins itself, because there is a damage to the muscle proteins because of some other things, so they are regulating the muscle tone. So I will not make a special attempt to discuss the muscular level. Then I will now go to the spinal level. What is happening in the spinal level? In the modulation of the spinal level is mostly it modulates through the inhibitory interneurons. It modulates through the inhibitory interneurons. I have just written 4 inhibitory interneurons: the recurrent inhibition by Rancha cell, the reciprocal 1A inhibition by the antagonist group of muscles, which we have already seen, and the non-reciprocal inhibition brought by the Golgi tendon organ, that is group 1B activation, and other presynaptic inhibitions which are coming from the descending inputs. So these are inhibited or excited by multiple descending fibers. So either these inhibitions may be inhibited directly, or there may be inhibition of inhibition that remains facilitated. So such things will modulate the tone. This is what happens in case of the spinal level. Now, just I give you here, this first one is the Rancha inhibition. The Rancha cell, if you are looking at if you are wondering about what is this Rancha cell is, so this is the alpha motor neuron reaching this thing, and it give a collateral here, and this collateral have a synaptic contact with the Rancha interneuron. This is a Rancha interneuron. This is also known as a Golgi bottle neuron, because it is described by Golgi. And this Rancha interneuron have a auto synapse with the alpha motor neuron, and this is an inhibitory neuron. Because the activity is going, and this is activated, and once it is activated, it wants to stop. And at the same time, this also inhibits this interneuron. So look at this, inhibit this inhibitory interneuron, supplying the opposite muscles, that is the extensor muscle. This is what is happening in the flexor muscles. This is what happens to the extensor muscles. So this inhibits the inhibitory interneuron of the extensor group of muscles, which is projecting to the alpha motor neuron of the extensor. What happens? Inhibition of the inhibition. That means it is facilitated. So that this is inhibited, and this is relaxed, and this is contracted. This is what the Rancha interneuron does. The second one we were talking about, 1A inhibitory interneuron. one inhibitory interneuron. So that means that you have this muscle spindle. It is going to the muscle. This is the monosynaptic contact and the monosynaptic fiber. Now it has a synaptic contact with the inhibitory interneuron, that is a reciprocal inhibition, and this is a flexor muscle, and this is an extensor muscle. And this inhibitory, it activates this inhibitory neuron, and this inhibitory neuron in turn inhibits the activity of this, so that this compartment or the extensor compartment is relaxed or inhibited, and this is a reciprocal inhibition. Now you have these modulators. These are modulators coming from the brainstem and the corticospinal tract. These are the modulators coming from the brain or supraspinal segment. They will modulate. Here also you see that this the Golgi bottle neuron or the Rensa interneuron receive inputs from the descending fibers from the coming from the brainstem, reticular system, vestibular system, or the corticospinal system. That is the Rensa interneuron. If you are looking at, already I have mentioned about the reciprocal inhibition. So this is the reciprocal inhibition, which I explained to you here. And this is in brief, clean diagram here. So the collateral reaches the interneuron there, and this interneuron inhibitory, and this will inhibit this flexor group of muscles, and there is a relaxation of this muscle. Now, there is another inverse stretch reflex. What happens if the muscle stretch, if the muscle contraction is too large or too powerful, too forceful? So now what happens? There is a fear of this muscle contracts very severely or rigorously. There is a fear of tearing of these ends at the tendon ends. To prevent that, there are specialized sensory organ, what are known as Golgi tendon organs. These are again spray nerve endings. They are distributed more evenly, or most like a spray and all through, and they are carried by the fast conducting fibers, and they are only activated when this is stretched too much, when the contraction is too much. So excess tension, and they carry, and they have an interneuron here. This is inhibitory interneuron, which supplies the same muscle. This is one alpha motor neuron of the same muscle that inhibits that, so that this muscle does not proceed or does not contract any further. Okay, I have mentioned about this thing, these Golgi tendon organs in series with the muscle. They are in series with the muscle. They require a strong contraction to excite them, and they will increase discharge in the group 1B fibers. And they have an interneuron, inhibitory interneuron here, and which inhibits the alpha motor neuron, and that would be responsible. Now, here what happens, I would like to explain this Golgi tendon or Golgi tendon organ inverse stretch reflex becomes the basis for the clasp knife effect in hypertonia associated with the upper motor neuron lesions. So in upper motor neuron lesion, what happens? There is already a hypertonic. The muscle is hypertonic. In that, you are if the muscle is you are trying to force the muscle, or you try to bend the muscle further. What happens? There will be a load or excessive stretch on these things, and this excessive stretch activates the Golgi tendon organs, and these Golgi tendon organs activate these interneurons, inhibitory interneurons, and so that they just give away. So that means just like opening up a clasp knife, in which when you are opening in the beginning, you have initial resistance, after it gives away. Same thing happens here. When you are trying to bend the hypertonic muscle in case of upper motor neuron lesion, there is a initial movement, initial this thing, and then suddenly it gives away. And this phenomena is known as a clasp knife rigidity or a clasp knife effect. Okay, so now this is only thing. Suppose if you are doing this thing in a very slow manner, you may not observe the clasp knife effect. If you are doing it, trying to do it briskly, the clasp knife or a lengthening reaction becomes very clear. I will describe this thing in detail when I talk about the spasticity. And this is the basis for spasticity. Now, coming back, the supraspinal controls. The supraspinal controls, I have put the here various elements of the supraspinal level. First element here is the antagonistic muscles here in the spinal level itself. Then we have the medullary reticular formation and the pontine reticular formation. We have the vestibular nucleus, and we have the cerebellum here. We have the medial cerebellum here, and the premotor cortex, and the motor cortex, and the cortico-reticular fibers, cortico-reticular fibers. So that means this is excitatory, this is excitatory, this is excitatory to this, and this is excitatory to the structure, the reflex circuitry. You have 1, 2, 3, 4. You forget about these two are converging on one and 2 excitatory. And this one is excitatory to the gamma motor neuron. If I am looking at the gamma motor neuron, there is only one excitatory gamma on the gamma motor neuron activity, one on inhibitory on the gamma motor neuron activity. And this one is directly on the alpha motor neuron. So that means this one is the gamma excitatory or facilitatory, this one is gamma inhibitory, and this one is alpha excitatory. So that means when the motor cortex sends impulses, it sends impulses to the whatever the flexor muscles. At the same time, that is inhibitory to the antagonistic group of muscles. Then comes here the premotor cortex. When it is activated, it will activate the medullary reticular formation. This medullary reticular formation descends down and inhibits the gamma motor neuron activity, decrease the gamma motor neuron activity. By decreasing the gamma motor neuron activity, they decrease the stretch reflex activity and they decrease the tone. This decreases the tone. And in case of this activation, there are activation by 2 levels, one by the cerebral cortex, another by the cerebellum. Both of these things, and this whatever is coming from the intermediate cerebellum, that is inhibitory here. These 2 excitatory aspects, if you are looking at, they would enhance the facilitatory activity on the gamma motor neurons. They increase the tone. And this diagram is also telling the same thing. I'm just putting back this summarizes whatever is written here. One is this is the corticospinal tract. This corticospinal tract is activating. This is a flexor alpha motor neuron. This activates the flexor alpha motor neuron. Now, this flexor alpha motor neuron has a receptive connectivity with the extensor alpha motor neuron. This is an extensor alpha motor neuron. So that means if it is activated, this gets inhibited. So that means the corticospinal tract indirectly inhibits the extensor group of muscles. Okay, so then then we have this corticorubral, that is this is a red nucleus here, corticorubral fibers, that is excitatory to the rubral, and rubrospinal is excitatory to the flexor group of muscles. So that is why we saw in case of the decorticate preparations and the decerebrate preparation. In decorticate preparation, it is the upper limbs flexed. In decerebrate preparations, all the limbs are extended. Okay, so now what is the rubrospinal is excitatory to the flexor group of muscles. At the same time, when this is exciting, this gets inhibited through the reciprocal contacts. Okay, so now we have the cortex. These are cortex to the medulla or medullary reticular system, cortico-reticular inhibitory fibers. These are excitatory here. They send impulses here, and these are inhibitory reticulospinal. Medullary reticulospinal is inhibitory to this extensor gamma motor neuron. Now, if this is gone, this extensor gamma motor neuron is not inhibited. And if this is not inhibited, what happens? It increases the spindle sensitivity, increases the spindle activity. And once it increases the spindle activity of the extensor group of muscles, this would be activating the alpha motor neuron. That is what it produces, increased tone. So I just mentioned, if you cut this thing here, inhibition is diminished, this excitation remains. So that means it goes unbalanced. There will be more stretch on these, or muscle spindle activity is enhanced, group 1A afferent activity increases. Similarly, here we have a pontine reticular formation. This is excitatory one. The pontine reticulospinal tract, this is this thing. Suppose if this is cut here, what happens? So now this pontine reticular system, if it is cut here, this inhibitory takes upper hand, the discharges decrease. The discharges decrease. And if this discharges decrease, so that will produce the decreased spindle activity that produces hypotonia. Now, if I come back here, in this situation, this pontoreticular formation, is well developed in human being, the pontine. And because of this thing, the intermediate cerebellum is sending excitatory inputs, and this is cut here. If this is cerebellum, this is cut here, this excitatory is lost, you may find hypotonia, because this becomes this takes the medullary reticulospinal tract or dorsal reticulospinal tract takes the upper hand. Now, having been described, this is about the circle is about the cerebellum. I have only looked into the two cerebellar nuclei, one vestigial nucleus, that is the medial cerebellum. So this medial cerebellum, I have put it here. This is inhibitory to the medullary reticular system. The medial cerebellar, that is a vestigial nucleus, and this is inhibitory to the reticulospinal, and also inhibitory to the vestibular nuclei, and that diminishes the alpha motor neuron activity. Okay, so now at the same time, this the Purkinje cells themselves, because the vestibular, some part of flocculonodular lobe uses the vestibular nuclei, and this vestibular nuclei, the cerebellar outputs from the flocculonodular lobe or a vestibular part of the cerebellum, they are inhibitory, and they will inhibit this vestibulospinal tract, they decrease. Now, then you are coming with the lateral or intermediate part of the cerebellum, and in the intermediate part of the cerebellum, it is the interpogitous, the nucleus interpogitous. In this case, it will be excitatory to the red nucleus. It sends the excitatory signals to the red nucleus, and this red inhibitory inputs, they will, if they are cut, they will increase these the flexor output. They will increase the flexor output. At the same time, that will inhibit the extensor output. There may be a hypotonia of the extensor group of muscles. There is one more component yesterday I was trying to discuss about. There will be ascending sensory fibers, especially from the anterolateral column. They will excite the pontine reticle formation, and this excitation increases the descending inputs to the gamma motor neurons. Anterolateral column sensations, these are carrying the pain and crude touch and the thermal sensation. And when they are carrying the pain, crude touch, or thermal sensations, you see the muscle guarding. When you have a pain abdomen, you have the abdominal muscles become tight. That is because of this input, increased pontine activity, increased gamma motor neuron discharge, and increased contraction of the same group of muscles. Okay, having explained this thing, we move on. There are a number of activities, muscle activities or hyperactivities. I have discussed 4 of them here: the spasticity, rigidity, dystonia, spasms. Spasticity, it's a velocity dependent component. It is triggered by the rapid passive joint movement. But the spastic resistance is only a temporary. It yields, it gives away. That is what the clasp knife rigidity. The rigidity, because all of them are hypertonia, rigidity is triggered by a slow passive joint movement. So say, for example, in case of the Parkinsonism, so there is a rigidity. So that means it's entire in the entirety. So these all the group of muscles are activated. They become rigid, tight. Dystonia is the term used for the spontaneous involuntary muscle hyperactivity. Spasm is triggered by the sensory or other chemical or other triggers. They will produce maybe this sensory stimulus, maybe either a pain or any other component. They will try to produce the muscle spasm, and this muscle spasm, and that would be producing the tightness, because they will not relax. In case of other things, they may be relaxing. So this is about involuntary muscle hyperactivity. Now I will come back to the spasticity because I want to discuss this component, because we use this term spasticity. This is a velocity-dependent increase in the tonic stretch reflex activity. Velocity-dependent increase in the tonic stretch reflex activity with exaggerated tendon jerks or tendon reflexes. If you are going back here, the spasticity is triggered by rapid passive joint movements. It's exactly rapid passive joint movement, that is velocity. Rapid is a velocity, and velocity movement is activating these stretch reflexes, and these stretch reflexes are now also associated with the enhanced deep tendon reflexes. They have this spasticity can be controlled at the spinal level, at the supraspinal level. The spinal level, as I have already discussed, it is the disinhibition of the alpha motor neuron in spasticity because of the following reasons. This is the disinhibition of the alpha motor neuron in spasticity can occur because of the decreased presynaptic inhibition. Decreased presynaptic inhibition means a greater 1A activity. Decreased disynaptic reciprocal 1A afferent inhibition enhances the activity of the other group of muscles, and that means that is not inhibiting, and that will increase. Decreased 1B afferent, that is the Golgi tendon reflex, that is what produces the clasping rigidity, and decreased ransom motor neuron activity, that is the recurrent inhibition. From the supraspinal level, the spasticity is because of the loss of balance between pontine and medullary, pontine excitatory and medullary inhibitory reticulospinal activity. Loss of balance between the pontine and medullary reticulospinal activity. Now I want to say that if the pontine is removed, so what happens if this is inhibited or removed? So this inhibition is not checked, it's not balanced, so it will be atonia. There is no spasticity. If this is removed, you look at that, and if this is removed, there will be more pontine activity, imbalanced, and that will increase the spasticity. So that means one produces the increased tone and one produces the decreased tone. Activation of the pontine reticular system. So pontine reticular system is excitatory by ascending sensory inputs. I mentioned, they persist. The ascending sensory inputs are a painful, thermal, or any other type of sensations carried by the interlateral column sensations. The inhibitory effects of the corticospinal tract on antagonistic muscle activity. Because corticospinal tracts are supplying the flexor muscles, they will try to initiate the contraction there. At the same time, there is a reciprocal inhibition to the antagonistic group of muscles. That is one part. The enhanced rubrospinal inputs to flexors. If the flexors are enhanced, reciprocally the antagonist group muscles are inhibited. These are all the causes of the spasticity. Now, if I were to look into these terms, the loss of balance between the facilitatory pontine and inhibitory medullary reticular system. So this is the facilitatory pontine and inhibitory. So this balance is lost. That is one cause for spasticity in the supraspinal level. And in this situation, suppose if this is lost, what happens? There is excitation from two ends. So one is from the cortico reticular, and here from the ascending sensory inputs. They will excite both of them. They will increase the gamma motor neuron discharge very great. Suppose if this is one of these things is lost, in that case, still there will be a greater gamma motor neuron activity. Suppose if this is lost in the entirety, so then the gamma motor neuron is in the control of the rubrospine or reticulospinal tract coming from this medullary component. There is a decreased tone. Now we have activation of the pontine reticular formation I have already mentioned about that, and inhibitory effects of the antagonist group of muscles. These will have a reciprocal inhibition. Enhanced rubrospinal, you just see that rubrospinal activity. If there is this activates, and this will come here to the flexor group, and this flexor group is activated, the extensor group is inhibited. So that's another component there. Now, what is hypertonia? Hypertonia is the increased tone of the muscle. This hypertonia can result from a number of conditions, either at the spinal level. If you are looking at the segmental level, it is below the level of the lesion after spinal injury and spinal shock. There may be hypertonia. The muscle tone is increased. But it may be because of the supraspinal involvement, as we have seen with the decerebrate, decorticate, and the midbrain lesions. I was discussing in my earlier lectures. All these things, there would be, if you are looking back to the previous diagram, when you have cut this thing here, it is a decerebrate preparations, and you have this one, there is a increased gamma motor neuron discharge, on the extensor group of muscles, and that would produce the hypertonia. Decreased basal ganglia or PPN outputs, and the basal ganglia is having a inhibitory output, results in the greater excitation of these. Now, increased pontine reticular activation is seen in anger. So if you have seen that when you become angry, every muscle becomes tense, and this tense is because of the increased gamma discharge, the anger, emotion, agitation, and other behavioral actions, or any other action which is associated with the adrenergic, increased adrenergic activity. That is also increases the pontine reticular activation. And decreased medullary actions, sometimes this decreased conditions may be suppressants, medullary suppressants, that increases and produces the increased gamma motor neuron activity. Dorsiflexion of the head, that will enhance the tonic reflexes, that activates the tonic reflexes, both the tonic labyrinthine and the tonic neck reflexes, and increases the gamma motor neuron discharge. When we are eliciting the deep tendon reflexes, we will ask him to pull the limbs or clench the teeth. When we do that, that is the gender risk maneuver. That would enhance the gamma motor neuron activity. Upper motor neuron regions, they form this decerebrate, decorticate midbrain. They will increase the gamma motor neuron activity and hypertonia. Drugs activating the extrapyramidal activity increases the hypertonia. This is about hypertonia. Coming back with hypotonia or atonia, and hypotonia or atonia result from a spinal level loss of 1A input. Say, for example, you go back here and you cut this, this is the dorsal root, 1A fiber. And if you cut this thing, there is no reflex activity, there is atonia. This muscle is not having any tone at all. So atonia. So that is one loss of 1A input. This may happen in case of a tertiary syphilis, tapes dorsalis, or posterior root lesions, or because of the vitamin B12 deficiency, as happens in case of a subacute combined degeneration. So I have mentioned about 3 conditions in which there is a hypertonia. Then there is a loss of alpha motor neuron activity, as happens in case of the poliomyelitis. Poliomyelitis destroy the alpha motor neurons, or amyotrophic lateral sclerosis that will also destroy the motor neurons, or the other motor neuron disorders. They will all decrease the alpha motor neuron activity that produce the atonia. They destroy the alpha motor and they produce atonia. Then from the supraspinal level, it is the decreased pontine reticular activation. During sleep, it is being suppressed. If this is suppressed, there is what is called a decreased activity. The muscle tone decreases. The hypotonia. Decreased pontine reticular activation during sleep, or increased activation of the medullary reticular system. So again, this will hold good during sleep. Both of them may be one is decreased and one is increased activation. And because the sleep is not a passive phenomena, it's an active phenomena, and this may be the reason for a sleep apnea syndrome. That means increased gamma motor neuron or decreased gamma motor neuron activity, and that results in apnea. Apnea results in the respiratory problem. A person wakes up because of the dyspnea or air hunger. That is the medullary. This is one of the causes for that produces hypotonia, and it is of medical importance. Then comes the cerebellar lesions, the intermediate cerebellum that control pontine reticular system. So now, if I am looking back here, the intermediate cerebellum, this controls the pontine nucleus, this nucleus, and this is excitatory here, and that is lost. And once that is lost, you have the decreased tone, atonia, and that is more evolved in human beings. In case of these things, cerebellar lesions, they will produce the atonia. Medial cerebellum suppresses the medullary inhibitory system. The medial cerebellum activity that would increase the medial cerebellar activity, they may suppress, and even the vestibular inputs or a loss of vestibular inputs, they will also produce. These are some of the causes of the hypotonia. Now, I now just give the differences between the spasticity and rigidity. Spasticity is a velocity dependent. So that is the velocity dependence. These are the points I mentioned. The velocity dependence, yes, this is when you do the stress or the passively do the or flex the limb in a rapid this thing, you will get the rigidity initially, and which gives away what's called a clasp knife. So that this velocity dependence present, it's not present. So whether it is you do it slow or fast, rigidity does not change. The movement is only for one group of muscles, either with the flexor group of muscles or extensor group of muscles. It is not for all. So that is one group of muscle is involved in case of the spasticity. In case of rigidity, both agonist and antagonist are involved. Both are contracting. So that is why you have that lead pipe rigidity. Length dependence, that is a stretch. So now when you stretch, there is increased resistance, and then at a particular level it gives away. So that is the spasticity is stretch dependent, whereas in case of rigidity, no way, it does not yield, because if you make a greater stretch, it does not give away. So it is independent of the stretch. The muscles involved, these are mostly, in case of a spasticity, these are anti-gravity muscles or extensor group of muscles, which maintain the gravity, posture, and weight-bearing joints. So now, rigidity is greatly seen with the flexor activity. So this flexor activity, you can just see the Parkinson patient. What happens? There is a universal flexion. He is already flexed, and maybe because of this region. What is the type of hypertonicity? It is a clasped PR in the spasticity, and it is lead pipe in case of rigidity, or a cogwheel in case of rigidity. And what are the conditions, clinical conditions that results in a spasticity? These are upper motor neuron lesions, whereas in case of rigidity, it is basal ganglia lesions. Now, if you are looking at the tendon reflexes are exaggerated here in spasticity. Tendon reflexes are not affected here in rigidity. And you can see the clonus. That means if you try to immediately flex it very fastly, there will be oscillations of the deep tendon reflexes. You may see with the clonus, and here they are absent. And in case of a spasticity, tremors are not seen. Here you may see the tremors. This one I have not listed. You can note down that tremors may be seen in rigidity. Tremors or the spontaneous activity or the tremors are not seen as a spasticity. These are the differences between spasticity and rigidity. Now coming back, what are the functions of the muscle tone? Muscle tone provides the priming for all the voluntary actions. It's a primer for all the voluntary actions, and it primes for all our posture and the postural reflexes. So that means this is the base or important postural reflex. I can say the tone is the unit of the postural reflexes, over which other reflexes will develop or will store. So that means even for voluntary action, this forms the base and over which the muscle contraction, either a distal muscle contraction or a proximal muscle contraction, brings in. That means for all voluntary actions, for all posture, it is a primer. And it is it serves the anti-gravity actions. It tries to hold on, support to the anti-gravity this thing, and it increases the blood circulation. One thing, and also increases the venous return, because the venous return is a more complex thing, and the muscle tone is important. In hypotonia, venous return decreases. What happens in case of the stroke or this thing? Less activity, less muscle tone, stasis, bed sores, and so on. So now the venous return becomes an important component or function of the muscle tone. It's a byproduct of the muscle tone, and even the circulation. It aids the circulation. That's important. And in addition, it is the metabolic major source of heat production in our body. And this major source of heat production, you can just see that increased tone during thermoregulation. In cold winter, your muscle, you are having an increased muscle tone, and sometimes you may find with the involuntary activity, that is the rigors. So that is the main source of the heat production. There may be many more functions of the muscle tone, and there are many more areas in which the muscle tone affected. You can look into it. I have broadly classified them in this lecture. To summarize, this is one important thing. Muscle spindle is a component, and in this muscle spindle, it is a static nuclear chain fibers. They will have a asynchronous activity on alpha motor neurons, and this asynchronous activity, because of the continuous stretch increases the gamma motor or the spindle activity, which in turn activate the extrafusal fibers. This is going through a secondary tube, and that produces the what is called a partial state of contraction, or the resistance that is the basis for muscle tone. Now, summarize, even when muscles are at rest, a certain amount of tightness or tautness remains, and this is called muscle tone. Because the normal skeletal muscle fibers do not contract without an action potential, you can just see that the muscle contraction cannot come with an action potential. It is because of the reflex activity generates the nerve impulses at a slow rate, and that produces the muscle contraction. This is what I explained on the basis of the myotatic stretch reflex. These nerve impulses, in turn, are controlled partly by the signals transmitted from the supraspinal level, that is coming from the brain and the brain stem, and even they may be originating from the spinal cord itself. Spasticity, rigidity, dystonia, spasm, and flaccidity are the conditions. Flaccidity is a atonia, and that is hypertonia. Now, the assignments, I have very few things maybe you may want to revise. Define muscle tone, describe the basis of muscle tone, briefly describe various factors regulating muscle tone. Then write short notes on spasticity and rigidity, hypertonia, hypotonia. I have given it. Please do it today. It will be very helpful. Okay, the reference books, this is, I have taken mostly from Kendall and the Samson Wright Physiology. And in fact, I have also referred Guyton's and Genong's to some extent, because some of the figures the Genong has given are there in the Kendall. The next class we will discuss on the brainstem reticular system. Till then, thank you.